My name is Paramdeep Bilku. I'm one of the research fellows at Aston University. My research area is ocular surface disease, and today I'll be talking about ocular allergic disease and how we can manage it in practice. So the objectives of the lecture, so hopefully by the end of the day you'll understand more about ocular allergy and understand it's a disease entity that's different subtypes, but also that it's confined to the eye, but can also involve other disease tissues as well, such as the nose and the throat. Also, we'll look at how we can manage it in practice from entry level through to IP standard, including a range of pharmacological options. The body normally responds to a bacteria or a virus where it will actually protect it from becoming infected, whereas with the pathogen which is associated with allergy, that pathogen is traditionally harmless, so it won't affect the body. So the body responds by producing an inflammatory response when there's no need to, and that can lead to the signs and symptoms of allergic disease, which can be quite irritating to the patient, particularly in more advanced cases which are associated with the eyes, which we'll discuss later. Ocular allergies are divided into 4 different subtypes. There's 1, 2, 3 and 4. They're basically classified depending on the types of cells that are involved in the pathology process, but also in the signs and symptoms that are presented to the patient in your practice. The main type is a type 1 hypersensitivity reaction. That's where the body has an immediate response to the allergen exposure, and they're the types that cause a red eye, which is typically encountered in practice. Type 1 associated or mediated by what's called an IgE antibody. That antibody is a major subpart of the process that we'll talk about later, and the different types and different parts of the disease process we'll discuss in terms of how it's presented, how the body responds, and how we can treat it. So by knowing the pathological process, we can then target the different parts of that process to treat it effectively. Generally, type 1 hypersensitive reactions, the people who have those sensitivities are known as atopic. So people who present to you with eczema, asthma, allergic conjunctivitis or dermatitis, for example, they are predisposed to these types of conditions. So it's worthwhile mentioning this as part of your history and symptoms workup, the type of conditions that they do have, rather than just broadcasting a general term allergy, because lots of people don't associate those conditions with an allergic disease. So just some basic epidemiology about ocular allergies. They're typically confined to the eye and they represent about 20% of all allergy cases. The type 1s are the most common, and in optometric practice about 8% of your patients coming through the door will present with some form of ocular allergy. However, people who have allergies, about 60% of them will have some form of ocular reaction. Those allergies might be contact dermatitis or eczema, but about 60% will get some form of reaction in terms of a contact lens reaction or to some solution or some eye drops that you use. So it's worth bearing in mind that as you go forward. So interestingly, in the literature, ocular symptoms are twice as likely to affect the person adversely compared to nasal symptoms, whereas in the literature or on the TV magazines or newspaper articles or on television, you'll notice that a lot of advertisements for hay fever, for example, concentrate mainly on the nasal symptoms, whereas it's the eye symptoms that actually cause most of the problem. But without targeting the eyes directly, you may not be able to treat them effectively. So in terms of prevalence globally, approximately 15 to 20% of the population has a form of allergy, whether it be ocular or nasal or otherwise. But a study in 2015, they actually showed that 50% of Europeans actually developed a form of allergy. And that was quite surprising, the sharp increase compared to what it was before. And the prevalence is, unfortunately, there's no real understood mechanism of how that took place. The prediction is that it's due to a lack of exposure to actual pathogens, so the high hygiene hypothesis become prevalent now due to an increased use of vaccines, a generally healthier lifestyle, use of shampoos, cleaning regularly. So before that time, before we had these more healthier lifestyle, which so to speak, the allergies were less prevalent. So this hygiene hypothesis has taken hold, but also that can't really account for the increase, such a sharp rise in the increase. And at the moment, there's a lot of research being done as why that is the case. Unfortunately, it remains an unknown, and that's something that we need to investigate further. In terms of the impact this disease has, in terms of allergies in general, a study recently conducted showed that about 3.5 million lost work days took place, about 2 million lost school days, and the economic impact was about £18 billion a year. So although it's a generally mild disease and self-limiting condition, it has a huge impact economically, both on a personal level and in the wider economic sphere. In terms of diminished quality of life, about 20 to 25% of patients reported that it had an equivalent impact on the quality of life to having a heart attack. So whereas in dry eyes it was about 50%, it was comparable to about 20 to 25%. So although it's less than dry eyes, it still shows that it has a severe impact on some patients, particularly in advanced disease. So in terms of a study that was done more recently, we actually estimated the cost on a personal level to how much allergies and ocular allergies were impacting on a patient. So for a pensioner, it worked out to be about £65 a year, whereas someone that was employed, it worked out to be about £125 a year. So although it's a relatively small amount, you can see that it's still an extra burden that the patient has to be responsible for throughout their working life. So hopefully the summary which I've given about the epidemiological impact in terms of diminished quality of life, the economic impact, the symptoms that it causes, we can see that ocular allergies pose a significant problem that need to be tackled, and that we are well placed in practice to treat these types of patients effectively, through from non-IP status with entry-level treatments, all the way through to IP status with the latest disease-modifying drugs that are available to us. Before we go on, it's good to discuss the pathology of type 1 hypersensitive reactions. They're the main ones that we encounter, and that's an immediate phase response. It's mediated by IgE, that's an antibody which circulates in the bloodstream, and it's divided into three main phases. There's a sensitization phase, then there's an early phase, which typically presents with the active signs and symptoms that patients normally see you with. Otherwise, there's a late phase as well. That happens only with chronic exposure, so you may not encounter that in practice. So I'm now going to go over to a diagram which will show you nicely, and I'll summarise the events that take place as part of those phases so we can have a clear picture of the underlying process in this disease. This diagram summarises nicely the cells that are involved in this type 1 ocular allergic response. And if you look at the image to the left, you'll see there's some pollen which has been bound to a mucosal lining. So that could be something like your nasal membrane, or in terms of the eyes, the conjunctiva. When pollen binds to the surface, the antigen, which is the pollen molecule itself, is then presented to what's called an IgE B cell. That B cell produces an IgE antibody, which is specific to that antigen, or the pollen. That IgE antibody then binds to the surface of a mast cell, and when there's enough IgE around that mast cell, it becomes activated. In other terms, it becomes sensitized. So upon next exposure to that same allergen, that mast cell will then be sensitive to that particular pollen or allergen. So upon re-exposure to the antigen or the pollen molecule, it then binds to the surface of the mast cell where the IgE have become sensitized. Once they bind to that surface, the IgE antibodies then cross-link, and that causes the cell membrane of the mast cell to become permeable. And as a result, it releases these inflammatory mediators, such as histamine. And that's the potent mediator which causes the signs and symptoms of allergic disease associated with the type 1 hypersensitivity reactions. So that forms part of the first phase of the disease process. The next stage is the late phase, and that's due to chronic exposure of the allergen. There's another type of cell called a T cell that helps to recruit what's called eosinophils to the site of inflammation. That's what causes swelling and the infiltration of these white blood cells to the site of inflammation, which potentiate the reaction and produce what's called newly formed mediators, which prolong and precipitate the reaction and cause chronic eye diseases in terms of allergy. So from this summary, we can see we have demonstrated the three phases of the type 1 allergic response. The first phase was the sensitization of the mast cell. Second stage was the release of the inflammatory mediators. That was the early phase. And then the late phase, that was where there's prolonged and chronic inflammation due to recruitment of white blood cells to the site. So as I mentioned before, the primary mediator of the allergic response is histamine, and that has effects on the blood cells, the conjunctiva itself, and the nerve endings, and they cause the signs and symptoms that are typically associated with ocular allergic reactions. What we see is on the blood vessels themselves, they have something called histamine receptors, and there's H1 and H2 receptors. And when they are activated by binding of the histamine to that site, it causes redness and swelling. And also it stimulates the nerve endings within that region, which causes the itching. And that's a pathognomic sign of the allergic response. As part of the late phase reaction, I mentioned there are some newly formed mediators that are developed, and they include things like prostaglandins, leukotrienes and cytokines, which all communicate together to potentiate this itching and swelling. So you can see on this slide there, the different types of newly formed mediators are causing redness and swelling, and potentiate an allergic response, which can lead to chronic eye disease and long-term consequences for the patient, and in worst case scenarios can lead to visual loss. So in terms of classifying ocular allergy, we mentioned there are subtypes of the reactions. We're going to focus on classifying it in terms of signs and symptoms because that's clinically more useful. In practice, you'll have to do blood tests or take samples before you can determine what type of reaction took place. But based upon the signs and symptoms, we can work out a formulated diagnosis, I should say, in order so that we can develop a treatment plan. The main subtypes are allergic conjunctivitis. They can be, again, divided into seasonal and perennial forms. There's also vernal carotid conjunctivitis, abbreviated to VKC. There's also atopic carotid conjunctivitis, again abbreviated to AKC. VKC and AKC can be considered the same disease but on an age-related spectrum. VKC typically affects younger in life, whereas AKC typically affects later in life, but the signs and symptoms are very similar. The main deviating factor is that the patients in older in life typically have atopic dermatitis concurrently. The other two remaining forms of allergic conjunctivitis in practice which affect the eyes are GPC, or giant papillary conjunctivitis, and contact and drug-induced allergy, which is associated with medicamentosa, which we'll discuss separately. So allergic conjunctivitis, that's the most common form of ocular allergy, and it's divided into two subtypes. I mentioned there are seasonal forms, and as the name suggests, that occurs at a certain time of the year, typically during the pollen season. Then there's perennial form, that happens throughout the year. So in those conditions, you can see that there may be some exacerbation in the perennial form, typically when the seasonal pollen levels are very high, but it tends to be generally milder. Signs associated with SAC, which is seasonal, or PAC, which is perennial, is typically to get conjunctival hyperemia, edema, and the stringy mucus discharge. You may get some papillae as well developing, so it's important that bacterial conjunctivitis is ruled out as part of your differential. Symptoms, classically you get itchy eyes and it's bilateral. A burning stinging sensation is not unusual, and you may get some watering of the eyes as well, so epiphoria is not uncommon. Photophobia, although rare, it can also happen as disease. So again, you need to think of the differential in terms of what caused light sensitivity as part of the differential diagnosis and rule those out first, because the worst case scenario, you don't want to overlook things like keratitis or uveitis. So if you look at this image here, we can clearly see that this eye has a very acute response here. The conjunctiva is clearly bulbous and edematous, and that's also known as chemosis. So edema of the conjunctiva, that's another term that we use interchangeably with chemosis. The eye, you can see that it's very glassy, very watery, and the conjunctiva swelled so much that the lower eyelid has everted itself. That's not done by application of a cotton bud or with the aid of a finger. That's done naturally due to the increased swelling of the conjunctival layer. There's diffuse hyperemia present as well. There is a watery discharge there that's present as well, and the eyelids themselves also become relatively puffy. So in terms of differentiating between the two, although they may present to you similarly, it's always worthwhile mentioning that what time of the year these symptoms develop. That way the patient can hopefully produce a diary of symptoms when it gets worse, and then you can create a plan around that to help manage it more effectively. Seasonal allergies are typically pollen or grass or tree or ragweed pollens. Perennial, typically caused by animal dander, such as the fur or feces of dust mites. So that's a classical misnomer. People associate dust mite allergy with the mites themselves. It's actually an allergic response to their feces, which isn't very pleasant indeed because you can inhale them. Signs and symptoms of the perennial disease are less severe, but they generally happen throughout the year on a more chronic basis. The mainstay of the treatment of these two conditions is basically avoidance of the allergen exposure in the first place. So by preventing the binding of the allergen to the site, it will prevent the process of the disease process that we looked at earlier from developing or taking place. So in terms of pollen and outdoor moulds, if you look at this table here, we can see the avoidance measures that would need to be undertaken by the patient. That can easily be written down or in print form or explained to them, so they can go away with the knowledge saying that this condition, it can be prevented. or technically cured by preventing the disease process from taking place. For pollen and outdoor moles, it's best to minimise the outdoor activities when symptoms are known to occur, monitor the pollen levels using either TV or internet or access to radio, where they give brief updates throughout the day. Wear close-fitting sunglasses and avoid rubbing of the eyes, because if you rub the eyes, that can actually degranulate the mast cells themselves, actually potentiate the reaction. So although it's very difficult, it's always worthwhile mentioning to the patient. Also, wash hands before going outdoors and after to prevent the pollen staying on your eye if you do rub the eyes afterwards. Also, options are things like closing windows and doors when the pollen levels are high, and using air conditioning to circulate if the air is very warm in the room, either in the car or within the home. When it comes to house dust mites, we recommend that you wash your bedding regularly, at least at 60 degrees on a weekly basis, and damp dust and vacuum weekly. Regularly clean all areas that gather dust, and reduce the humidity in the home. Basically, dust mites prefer humid conditions in order for them to reproduce and increase their population size. So by reducing those levels, they help to hopefully reduce their prevalence within the home. So ways to do that can also be achieved by using a dehumidifier. If there's an animal fur issue or animal dander issue, try and avoid contact with animals. It goes without saying. Any pets that reside in the home, if you do have them, then make sure they remain outdoors when they're sleeping or when you're not present at home. Regularly vacuum and clean the home, and wash hands, clothes, and avoid rubbing eyes or nose after contact with these animals. Moving on to the treatment of these conditions. So often avoidance strategies aren't completely effective, so inevitably there will be some need for some treatment intervention, either in form of an eye drop or otherwise. Now, in terms of non-pharmacological treatments, from an entry-level perspective, they're very basic things that you can offer for the patient. So things like a cold compress, that can lead to vasoconstriction of the blood vessels and then prevent the leakage of any fluid, which can then, again, in turn prevent any chemosis and then relieve the signs and symptoms associated with that condition. Also, you could use artificial tears by copiously applying it to the eye. You're not only washing out the pollens from the eye, but also diluting them as well, but also acting as a lubricious surface contact between the eyeball surface and the underside of the eyelid, minimising any interaction between any papillae that may be present. If they're ineffective or the patient has still got symptoms despite effective treatment plan, you could then look at pharmacological options. So things like mast cell stabilisers become necessary. Now, as the name suggests, they prevent any degranulation of the mast cell themselves. So then what's known as a competitive antagonist of the IgE receptors on the mast cell surface. So by taking the drop in the eye, the mast cell stabilising molecule, that will actually bind to the surface of the mast cell itself, then preventing any binding of the pollen or allergen itself, again preventing the degranulation of its contents and the potentiating the reaction. Now, as the name suggests, it prevents the reaction from taking place, so during the active phase they're not particularly effective, so there is a loading dose that's required. So hopefully if the patient has kept a diary or you'll be able to pinpoint the allergen itself, you can then work out what time of the year they need to start using that loading dose. The loading dose is typically a week or 2 weeks before symptoms are known to develop. Now, the drug types that are available, there's sodium chromoglycate, there's lidocarymal sodium as well, and lidoxamide. Some of these drugs are available as P only, so they can be sold and supplied in the course of normal practice for your patients, but it's also dependent on the pack size and the formulation of the drug itself. So the next drug class that's used in practice are antihistamines, and as the name suggests, they're used to actually prevent the histamine from binding to the effector sites, which would otherwise normally cause the allergic reaction response. So the H1 and H2 receptors on the blood vessels, they are then bound by this competitive antagonist, the antihistamine, which then prevents the binding of the histamine and again will prevent any allergic response. So they're very good in the active phase of the disease. So if the patient presents with a red and very itchy eye, an antihistamine is a good option to prevent it, and they're very fast acting as well. They work within about 10 minutes of application. Now, most of these antihistamines are typically only, unfortunately, POMs, so prescription-only medications, although there is one that's available over the counter. So the drug types that are available are typically combined with a vasoconstrictor, such as oxymetazoline or xylometazoline, and the drug that's available over the counter for sale and supply is Otrivine Antistine. That's combined antizoline sulfate with xylometazoline, and that can only be unfortunately used for up to 7 days maximum due to a vasoconstrictor rebound effect, which we'll talk about later. Now, if other parts of the body are involved, let's say there's a general broad spectrum hay fever, is the itchy nose, a runny nose or an itchy throat as well, you can also offer an oral antihistamine. because that not just targets the eye, that also targets the systemic involvement as well. So one thing to bear in mind is in terms of treatment is that if we actually target the tissue directly, that's with topical application of a drug rather than systemic use of a drug, we can then provide a more effective dose to the target tissue. So if we take a systemic medication, you may not get as good treatment response. You may require longer treatment, but also the actual symptoms may still be present. So by targeting the tissue directly by applying a drop topically, not only do you increase the dose on the eye, you also may resolve symptoms sooner, and that patient may require less treatment in the future. Now, more recently, the first choice drug to go to nowadays is what's called a dual action medication. That combines the antihistaminic properties and mast cell stabilising properties of the drugs that we've suggested, or what we talked about already, in one solution. Now, the most go-to drug now, the first choice drug, is what's known as opatinol or olopatadine, and also the drug names such as epinastine and ketotifen. Now, these drugs, again, unfortunately, are prescription-only medications, but they are very effective as preventing the allergic response, but also during the active phase, and also have the benefit of only requiring twice daily dosing. Mast cell stabilisers themselves require 4 times a day dosing for sodium chromoglycate, whereas things like edoxamide and edocromil, although they're less common, they also have twice daily dosing, but they're not as effective as olopatadine. I did mention another drug class, that was vasoconstrictors. They have a limited shelf life because they do cause what's called rebound hyperemia. Now, with prolonged vasoconstriction use, the receptors themselves become fatigued, so over time, rather than causing vasoconstriction, it results in vasodilation, and again, the redness returns. Again, the leakage of the contents from the blood vessels themselves, chemosis returns, the itching returns. So they're only useful from the short phase or early phase of the disease process, but you should warn your patients they only have a limited shelf life in terms of how long you can use it for. So if patients are still developing symptoms after 7 days, you should stop the drug and look elsewhere in terms of a different or alternative medication. So we've just discussed some IP options and non-IP options, but this next slide shows a list of drugs that are available over the counter or pharmacy-only drugs. So these can be provided in the course of the sale and supply of your normal practice. So the drugs listed on the slide here, they're things like sodium chromoglycate, lidoxamide, antizoline and xylometazoline, and the oral antihistamines, such as Piriton and Benadryl. They're typically bought over the counter. These are available at your disposal. They're also dependent on the pack size as well. So if the patients are running out of drops, do be conscious that the pack size is relatively small. So do be aware that you may need to keep providing repeat prescriptions for them. Also, one thing to bear in mind, although they're P-only medications, you still need to write down the exact name, the dosage that you provide, the frequency of application, and how long to use it for as well. So they're no different to any other medication. So just to reiterate, P-only medications are pharmacy-only medications, and POM medications are prescription-only medications. So this list here are those that are P-only. So these can be provided in the course of your normal sale and supply of medications in your normal practice from entry level. So a lot of your patients are contact lens wearers, and that's why I brought up the next few slides, because a lot of contact lens wearers are quite have a barrier in terms of they don't want to give up their lens wear in order for you to treat them. So although they have an eye problem, they are very reluctant to actually wear glasses. So there are some options available to you. Now, the typical paradigm that is well known or well established is that allergens can actually bind to the contact lens surface, but when they bind to the surface, that can actually potentiate the reaction. That's why practitioners generally advise patients to prevent their wear or stop wear whilst you have these symptoms. So management, like I mentioned, was typically involved ceasing lens wear and then starting some form of medication or allergen avoidance until they quiesce. However, some newer anti-allergy drugs that are available in terms of twice daily dosing medication have shown that it is possible actually to wear contact lenses whilst you're actually treating them as well. So a study by Brodsky in 2000 actually showed that they could increase lens wearing time, I should say comfortable wearing time, and overall comfort by using twice daily dosing of olopatadine. And that was done throughout the allergy season. That was in comparison to a vehicle drug. So they actually show that they can improve the comfort and wearing time whilst wearing lenses. So your patients may approve of that. Another study, also done more recently, 2009, Nichols found that they could also increase lens wearing time and comfort following 1 drop of epinastine prior to lens wear. So putting a drop at the beginning of the day, waiting 5 minutes, and putting on your contact lens seem to help maintain lens wear whilst also controlling the signs and symptoms. So other options which could involve in preventing the use of any of eye drops or pharmacological options are actually increasing the lens replacement frequency. So by increasing the lens replacement frequency, it minimises the buildup of the allergen on the contact lens surface, so then again prevents any further exposure and the allergic reaction from developing. Also, by wearing daily disposables, if they have an additional lubricating property, it's been shown in a recent study by Wolfson and Emberlin in 2011 that they could actually prevent the actual onset of symptoms by actually wearing lenses themselves. So not only did they reduce symptoms in comparison to no lens wear, the actual effect was enhanced by actually having lubricious agent on the surface. So from that perspective, we can say that a contact lens acts like a barrier to further exposure. So particularly in patients who have a larger lens diameter, this effect was more pronounced. So a contact lens can therefore have a barrier effect. So leading on to that, allergies in contact lens wear, the most typical manifestation of allergic reactions with a contact lens wear is GPC, that's giant papillary conjunctivitis. Signs and symptoms are very similar to SAC and PAC, but you get a large cobblestone appearance underneath the eyelid on eversion. Now these papillae are generally about 1 millimetre in size or larger, and there's a copious mucus discharge associated with it as well. If we then look at the diagram, you can see on this eyelid it's been inverted and stained with fluorescein. You can clearly see the cobblestone appearance, and it's quite severe in this case. Now, you would expect that when the patient has removed the lenses, they'll be under some significant discomfort. So hopefully, even if by maintaining contact lens wear, you'll create that barrier effect again and hopefully prevent any further discomfort. So in that case, it may be wise in this instance to maintain lens wear and use the additional eye drops before and after removal of the lens. So treatment of GPC, typically the GPC is actually a response to a mechanical irritation rather than a true allergic response, because it can also be present in people who have ocular prostheses or sutures in the eye as well. So if you actually optimise the lens fitting of a contact lens on the eye, rather than removing it completely, that might resolve the issue itself. So preventing the actual mechanical irritation, making sure the lens moves effectively, there's enough tear film circulation underneath the lens, and it's a good wettable lens surface, that can hopefully reduce the inflammation and reduce the size and appearance of those cobblestones. You may want to switch to a different material, change it to a more stiffer material, or less commonly to a gas permeable. Now the benefit of switching to a gas permeable is that it has a smaller diameter, so there's less area for the lens to disrupt the epithelial lining of the conjunctiva on the palpebral surface. So the region of the papillae is then minimised, that's affected. However, there's often a combination of these lens options by changing the fitting, the modality of the lens wear, the material, which seems to produce a more effective result. So don't be disheartened if after the first attempt that it doesn't work. You can then you can have another go at changing a different part of the lens wear schedule to help prevent the symptoms. However, again, it's inevitable that some cases won't respond to just by changing the lenses. You may need to introduce a drug type. Now, the drug that has been approved and has a huge background of research to support its use in this condition is the use of mast cell stabilisers. So chronic use of sodium chromoglycate 4 times a day or twice daily for up to 6 months is not unheard of to help to prevent this condition from taking place. And also you may want to prevent contact lens wear if the cornea becomes involved. Now, in terms of a disease entity that can cause a severe corneal involvement, we're now moving on to VKC, or vernal keratoconjunctivitis. conjunctivitis. This is a chronic bilateral disease, and it's classed as a type 4 hypersensitivity because it not only involves IgE, but also the eosinophils and T cells, and they actually produce that chronic long-term late phase response, which potentiate the reaction in the eye and causes chronic disease process. The patients that you'll present to, they're typically 3 to 25 years of age, mainly male, and they typically are from warmer climates. The disease is relatively uncommon. It's about 0.5% of ocular allergy cases, and it typically peaks at about puberty and then quiesces over time. The signs and symptoms, again, are very similar, but in addition to the cobblestone appearance with a GPC, you may also get these limbal papillae. And where they become scarred on the top, they become calcified, and they are known as Tranter's dots. Now if you look at this slide, you can see that large papillae underneath the eyelid, and you can see that there's actually no fluorescein in the eye there. That's actual mucus discharge, and it's quite copious indeed. Now that's as a response to the eye having this rough surface. The eye wants to produce this mucus to minimise that interference and reduce the friction between the eye. So it's a natural consequence that they'll produce this copious amount of mucus in the eye. The image on the right, you can see those papillae around the limbus. And the image at the bottom there, you see that's actually what's called a shield ulcer. So this is a real threat to vision. Now, although it's generally sterile, there's no infection going on, it has a potential to become infected. And so this disease entity needs to be monitored very closely because of the potential for visual loss. So these sterile ulcers develop as a result of friction between the cornea and the giant papillae on the underside of the eyelid. So essentially, the papillae are actually rubbing away the epithelial cell layer and preventing the actual cells from actually replicating and healing. So this shield-type shape ulcer develops, which matches closely to the region of the papillae on the underside of the upper eyelid. So rather than being infective in nature, these are then sterile in nature. So in any case, we need to watch for any infection that may develop, and that's typical signs would be hypopyon development due to anterior chamber reaction, a region of edema underlying the actual lesion itself, and also any excessive hyperemia or redness around the eye as well, which is more diffuse rather than localised. So in addition to those signs of infection, the symptoms would be an increase in pain, photophobia, and an increase in lacrimation. AKC, like I mentioned earlier, that's actually very similar in nature to VKC, but it tends to happen later in life. So these patients typically over 50 and are associated with people who have atopic dermatitis. So in fact, 25 to 40% of AD patients, that's atopic dermatitis, have an ocular manifestation such as AKC. Again, the signs and symptoms are very similar, but the patients also present with dermatitis around the eyelids. So if we again look to the slides, we can see there's a thickened and macerated eyelids, there's some missing eyelashes, there's some eczema around the eyelid, it's very puffy and generally looks very unwell. Again, the image on the right there, you can see some corneal involvement. That patch there, that's an ulcer that's developed there with severe infiltration. You can see the edema around the mid-periphery and centrally, but also the white appearance of the ulcer demonstrates the accumulation of the white blood cells at the site of the inflammation. And again, that just clearly demonstrates the process going on in the eye. Due to that eosinophil recruitment, the white blood cell recruitment is part of that late phase response. So treatment, inevitably we may have to use pharmacological agents. Mast cell stabilisers are the mainstay of this condition, but due to the nature of this condition, you may need to introduce some steroids. Now, these steroids are powerful anti-inflammatory drugs. They interfere with the late phase response as part of that immune condition. So what they do is they actually prevent the production of the late phase mediators that are developed, and also interfere with the messaging of the cytokines and the adhesion molecules that we mentioned earlier. So by doing so, they block the release of enzymes which would otherwise cause this inflammatory response and late phase response. Now, steroids, although they're very powerful and very effective, they also require close monitoring. The side effects are typically increase in intraocular pressure, cataract development as well, but they also may delay corneal healing. So you need to watch for the wound on the cornea from breaking down more readily. So by maintaining this anti-allergy drops, these steroid drops, antibacterial drops to prevent infection, you need to still watch very, very closely for any adverse events that may take place. Now, to reduce the impact of any side effects, you may want to use a softer steroid, so things like loteprednol or ramoxicillone or fluorometholone. They're generally less penetrating towards the anterior chamber so that they don't produce this IOP elevation, but still you have to watch for that carefully. Now, in patients who are steroid responders, you may want to consider a non-steroidal anti-inflammatory drug. So they're the alternative to steroids. So these inhibit the cyclooxygenase pathway, which normally produce, again, the late phase response and the production of the prostaglandins, which can cause the inflammatory reaction. Now, these drugs, again, there are some contraindications as well. So patients with nasal polyps or asthma may get to develop a bronchospasm with these drugs. So you may want to avoid this in this condition. So if they're unavoidable, there are other drugs which we'll talk about next. So these are immunosuppressive agents, so things like cyclosporine or tacrolimus. These are generally ointments, so they're either formulated in a hospital pharmacy or they're actually made specifically for that patient. So cyclosporine has been known to be mixed in oil in 2% formulation, and that's been shown to be effective in VKC and AKC in cases unresponsive to steroids or to NSAIDs or where they were contraindicated. Now, there has been known to be no systemic side effects of ocular application. What I should say is topical application, but they do produce side effects because they are immunosuppressive agents. When they're applied to the eye, the main side effect is a stinging sensation upon application, but that normally wears off after a few minutes. Now, I also mentioned about the corneal ulcers, so they can have the potential to become infected, although they are sterile. So, in cases where they are infected, you should ideally take a swab and develop a culture and look at the bacteria which are present in that culture, and then determine which of those bacteria are then sensitive to particular drug types, which can then be directed to that patient. So, the most stronger drugs that you should be using are fluoroquinolones, so things like ofloxacin, ciprofloxacin, or levofloxacin. These are more effective rather than a broad spectrum drug such as chloramphenicol. So by nature of the fluoroquinolones, what they do is they actually attack the bacterial cells directly by causing cell lysis. That's the breakdown of the cell membrane so that it releases its contents and effectively kills the cell. Whereas chloramphenicol is bacteriostatic, it actually prevents the reproduction and replication of the cell, so it prevents it from increasing its number. So by attacking the cells directly by reducing the bacterial load, that tends to be more effective in this condition. I mentioned earlier, if this is untreated or that you don't watch this carefully, it can lead to blindness. So it needs to be watched very, very carefully. So close monitoring, either every 2 days or on a weekly basis, is necessary in these conditions. So I did mention earlier, there's another form of allergy. So we looked at the clinical perspective in terms of the disease entities. There's also something called contact allergy. And that's associated with contact dermatitis. So if you're exposed to a certain allergen or a certain washing powder or makeup, you can get very itchy and a scaly skin that can develop as a result. The eye is no different. If you get a drug-induced reaction, it can cause something called medicamentosa, and that's a toxicity reaction which can cause, again, itching, redness and swelling of the tissues of the eye. These swellings and inflammation or hypersensitivity may be due to the preservatives in a contact lens solution, overuse of a drug, or some certain drug types. So the older drugs that are not really used anymore, things like pilocarpine for miotic use, that can tend to cause an allergic reaction in the eye, and gentamicin as well, another antibiotic which is not very pleasant when it's applied to the eye. It causes stinging, but if it's used chronically, it can cause a breakdown of the cell membrane and cause a stinging issue. So in terms of treatment for medicamentosa, although if we can identify the actual causative agent, by stopping that, we can actually prevent the reaction from taking place, and thereby the use of treatments isn't necessary. But if the patient is in significant discomfort, you may want to advise some topical lubricant. But it's also worthwhile mentioning it's self-limiting, and that by stopping the agent, it will prevent the actual reaction from developing. Shampoos, cosmetics and irritants, they're no different. So bear in mind that when you do a workup, in case you suspect this contact allergy, that you can exclude those as a possibility. So ask them, have they changed their shampoos? Have they changed their cosmetics? Any changes in the ingredients of those products that you're using as well. If you do notice that there has been a change, then advise the patient to either stop using it or seek an alternative. Another area which is less common is photocontact dermatitis. Now that's where you get a UV exposure and it causes red, irritating skin, but also you can get UV exposure to the eye and cause photocontact keratitis. So basically photo-induced keratitis. So again, you get signs and symptoms of itching, but also you get this breakdown of the corneal epithelium. You get a diffuse epitheliopathy across the surface. Again, by its nature, you need to prevent the reaction from developing, and treatments typically with lubricants until it resolves. This next slide we're looking at now, we're going to look at the differential diagnosis of ocular allergy. I did mention that itching is a pathognomic sign, so if someone does mention itching and it's bilateral, it's likely to be an ocular allergy. The other conditions that we want to look at to exclude are things like dry eye. Again, that's also bilateral, but what you want to look at is the patient itself. The patient in dry eye is typically older. They generally have symptoms which get worse towards the end of the day. They also have this, it's a chronic issue. And if you do some tests to differentially diagnose, you'd want to look at the tear film breakup time, for example, look at the tear meniscus, and look for the presence of any staining, which is typical of dryness in the eye, and that's the inferior third of the cornea. So blepharitis, that also forms part of the differential. So again, that's also bilateral. It causes itching or irritating eyes. But again, on the slit-lamp microscope, you should be able to look at the eyelashes directly. You'll be able to see any collarettes or crusting around the base of the eyelash margin. There may be some posterior blepharitis involvement as well, some meibomian gland dysfunction, for example. So careful inspection of the eyelash margin is crucial to help you differentially diagnose. The different infective conjunctivitis as well, so viral and bacterial, typically they follow a cold or a recent flu or exposure to someone who has had a recent cold or a flu. And again, it typically starts in one eye and then presents to the other. In viral conjunctivitis, if you avert the eyelid, you may see some follicles and also may get some lymphadenopathy. So if you palpate the submandibular nodes or the preauricular nodes, you may find some inflammation there. That could indicate a diagnosis of more viral disease rather than allergic disease. If it's bacterial, you may also see some papillae, but also some mucus discharge, but the history should really point you towards a diagnosis rather than any clinical tests. In those cases, the differential would be the presence of follicles and viral disease, and a bacterial conjunctivitis, the sticking or matting of the lashes upon waking. Another condition that's less common is superior limbic keratoconjunctivitis. That's often overlooked again, so you should stain, apply fluorescein to the eye or lissamine green. You'll be able to see some pannus formation in the superior limbus on the cornea. You may see some scarring or some epitheliopathy. And again, in those cases, that's usually due to an abnormal contact between the eyelid margin and the cornea. So in that case, use of lubrication or bandage contact lens usually works effectively. Another condition that shouldn't be overlooked is molluscum contagiosum. So that's a human virus, a papillovirus that can infect the eyelash margin. And it normally develops as a dome on the eyelash and it can cause conjunctivitis. So there may be repeat episodes of this and the patient keeps reporting it happens at a certain time of the year. It's frequent, it keeps returning. And so you may suspect allergy, you may suspect there must be an allergen that they're exposed to. But by careful inspection of the eyelid margin, you might see this dome-shaped lesion, which is umbilicated. And if you squeeze it, you actually get this cottage cheese-like exposure or this like a toothpaste-like content that gets expressed. And that's very contagious, and that can cause this long-term and repeat episodes of conjunctivitis. So that should be referred either to be excised or use of some antiviral agents. Also, to rule out is medicamentosa. So if there's any drugs that are used in both eyes together, if it's applied to the eyes, that can cause this contact allergy, which I mentioned, and that's quite distinct to a pathogen or allergen, which is causing a more common condition such as SAC or PAC. To summarise then, so allergy is a hypersensitivity reaction. It's normally harmless substances that cause this reaction, so its body's abnormally reacting to it. Ocular allergy, that encompasses a group of allergic conditions, typically affecting the eye, but it can involve other tissues as well. So where other tissues are involved, you may want to use an oral antihistamine to help prevent any symptoms systemically. Ocular allergy, like all allergies, they're increasing in prevalence, so we need to take this condition more seriously, particularly in light of the economic impact, but also the impact on the quality of life. Initially, you may want to start talking about allergen avoidance strategies and non-pharmacological options to help the patient to prevent the reaction from happening in the first place. But in some cases where that's not possible or those methods aren't effective, we may want to switch towards a pharmacological agent such as mast cell stabilizers, antihistamines and dual-action medications. There's a wide range of drugs available, and again, depending on whether the patient's a contact lens wearer or not, you may want to adjust your treatment plan so that you can provide the best possible course of management for that patient, particularly if they want to wear contact lenses throughout that period. Majority of these conditions, as we can see, we can manage to resolution in practice, as some drugs are available P only, so that entry-level optometrists can effectively manage these conditions. However, the more severe end of the spectrum, the VKC and the AKC, that does require more close monitoring and the use of pharmacological agents, namely prescription-only medications and steroid drugs. And also, as I mentioned before, systemic medications are useful where other tissues are involved. So hopefully I provided a nice summary of the ocular allergic disease, and we've met the learning objectives in terms of different types, what methods we can do to identify and diagnose the conditions, and the different drug classes available to treat these patients in your normal course of practice.